here and maybe trying to bring in some of the basic scientists that are still here is inflammation, which is sort of disappeared for a while and is making a comeback. And I was interested in, I guess, the clinical perspective. What do the clinicians think, what do the basic scientists think about the role of inflammation? And is it clinically important for us?
Great, good. I do believe it's important in the early stages, and you know what I'm going to say, but in these early reactive tendons, I think it gives an insight, you know, we can ascertain, in fact, is it inflammation or not? I'm not going to go there, but let me say just an early reactive tendinopathy that gives us some directions in terms of what we would do to the treatment, in terms of treatment, certainly what we wouldn't do in terms of no intratendinous injections, no heavy load eccentrics, you know, things that, you know, can often prolong these things for up to 6 months more than necessary. And so I think giving some consideration around, you know, inflammation, early reactivity or whatever, and just respecting that in our ongoing management.
So I guess you're saying the acuteness of the response, or an acute response, call it reactive or call it inflammatory, and you are sitting so on the fence.
I couldn't be on the same fence.
Okay, so more about the acuteness and the strength of the response.
Ebony Rio, just getting on to our language, which Joe talked about earlier, I actually have a real passion about our terminology, and I think there's some dangers clinically in revisiting inflammation in terms of what it conjures up for the patients, because for most people that's quite a passive therapy, and I think probably as a group we might agree on one thing, that load and load management and exercise is really important in their recovery, rather than simply, you know, a one-pronged anti-inflammatory approach, because I think that's been tried extensively in the past. Again, I don't know what we should term it or whether or not we can even agree on the definition of inflammation, but I think clinically our language is really, really important.
Maybe the degree of importance to divide into acute and chronic. Inflammatory reaction may be more prominent in the acute reactive tendinopathy, while less inflammatory response in chronic phase. So what do you think about that? Could that be of importance? You divide your patients in considering inflammation in acute ones and chronic ones?
I think Sam hasn't. I just think the danger in involving inflammation terminology-wise suggests a need for acute inflammation management, ICE, and maybe the benefits of anti-inflammatories, and it changes the focus of the management in the early phases to liken it more to other musculoskeletal injury, where, you know, the management should be very specific to a tendon management process.
Is there any basic scientists who want to comment on that? Because we've certainly had a clinical perspective, but do we have anyone from the science that would like to have an input?
Yeah. The thing that is striking is that there is no real therapy today. When you analyze the causes of tendinopathies, you see there is destruction of the structure. You see that there are some degeneration process which cannot go to the end. And it looks like in many other cases the same. I mean, it's not only tendons, it's also for many pathology that's under an acute or non-acute become chronic. Now the whole thing, when there has been attempts to find treatments, has been to analyze what are the elements that change, what is there. You always try to make a sort of catalogue of all the elements, and then we realize that there's so many factors that are involved that in reality there is not one approach. If you look at more global approaches which have been recently developed to bring into the wound new cells like stem cells, or to combine with a sort of mixture of growth factors. But I think that an approach which you should consider is the one that I personally have developed for many years now, not yet in tendinitis, is a global approach of recreating the microenvironment. That is an understanding of what is the extracellular matrix organization, and through that restore this microenvironment so that the elements which are naturally there can be reconstituted so that you can reorganize, and the whole architecture is so central. And among this understanding, we found that glycosaminoglycans, and especially the heparan sulfate, seems to play a complete central role in the regulation of tissue homeostasia for several reasons. First, it's a glycosaminoglycan which is ubiquitous but binds to the matrix protein at the sites called heparan sulfate. And when there is an injury, the structures are destroyed. It's one of the very, very first destroyed. And those molecules, those glycosaminoglycans, I'm talking about the sugar part, play also another role, is to capture the communication peptides. That is, almost all the known growth factors and all the most cytokines and chemokines bind to heparin. And in fact, our understanding in any tissue is that those molecules are storing and protecting those growth factors. So by restoring and introducing this type of molecules that will replace the heparin, we can restore the architecture and microenvironment and restore the information which is naturally then done by the cells. So altogether, we restore the microenvironment and we restore the regeneration process.
So if I understand it correctly, you want something to be injected into the tendon to try to restore?
Well, injected, administrated by one general way or not, yes. It's a local, it could be a local or systemic, this both work. Yeah.
Something inside the tendon?
That would, yes, that would bind to the available binding sites of the destroyed extracellular matrix.